want to thank you all for starting your day and your week with us today. Dr. Wheeler is here with us to talk through kind of our proposal relating to the vote that's going to be taking place on Thursday. Wanted to have a chance to meet here at Abbott with staff and have people have an understanding, and also a chance for a dialogue and questions to be answered. Dr. Wheeler's presentation takes a little over 15 minutes, and then we'll have time for questions, and we'll try to get to all the questions that we have. So I want to thank you all for coming. Thank you for all you do here. I think this has been one of the more difficult summers in my time here at Abbott, and I've described it in other settings as having been one of the most heartbreaking things I've gone through in my career in healthcare, to watch the challenges for our team and trying to understand how we can bring things back together and find a solution for this. But I think we're here today in the spirit of trying to find that solution, and with that, I'll turn it over to you.
Thank you. Boy, full house. I really thank you guys all for being here. This is, as Ben said, this is a heartbreaking time in many ways, because I think all of us share one common mission and purpose, and that's that we get an opportunity every day to impact lives in a positive way, and we like to work together as a team to do that. So to talk about this is this challenge is difficult, but I want to, and I'll commit to you to being as open as I possibly can be about every question asked. I want to talk to you a little bit about why we approach this way, and want to just see what you have to say and some of the questions you have. And I'll have to say, for me personally, these things are especially, the stakes are high on this. How we care together for the people in the community we serve, there's no higher stakes than that for this. For me personally, this is my home. Abbott Northwestern is my home. I've practiced here for over 20 years. I have wonderful relationships with many of you for over that time, and those treasured relationships are now strained. So both personally and professionally, this is a challenging time. What we wanted to do, we know there's a whole lot of information out there. What I learned was try to communicate things in different ways. I didn't know who would come through the door or how people would come through the door, but I'm really glad you're here, that we have a chance to have this. I also got to tell you, there's some trepidation. I don't know how it's going to go. Sometimes what I want to do is walk through just kind of our proposal. We opened it to everybody because this affects our nurses, and this proposal will speak directly to the nurses part, but also affects everybody in our organization. Because once anything disrupts or has a potential to disrupt our care for the people we serve, that affects everybody, which is why we chose to open to everybody today and answer the questions involved. The other thing I'll say is that we would much rather still be negotiating than having a vote on contract on Thursday that we think could have been something ultimately that we could have wrestled together down to the ground, so that both of us would feel like there was something that was given and something that was gained, and we could have a proposal in front of the vote that was endorsed by both. I think that we didn't get to that point, and it looked promising in July 22nd when we were starting to talk about some of these issues, and I thought we were going to wrestle them. We didn't get any farther on August 1st when we were told to put a proposal in front of people to vote. I wish we had gotten to a point, quite honestly, wish I had had a key to lock everybody in and get wrestled it to a point where we had wrestled it, but this is where we are now. So at least I want you to understand kind of our part of this, our perspective. I know that nurses have been instructed to delete things from negotiation news and the like. I know you've gotten a lot of information. I know you're educated. I know you've read a lot of the information. I want you to read everything from M&A, everything, and I want you to see what we have to say about this as well and make the best decision that you make. It's important to get all the information. This is just another forum for you to get some of it and for us to hear from you about what questions you have. So with that, let me go into this. And then let me open it up for questions. So if I can get all the way through this, I'll try to do it in about 15 minutes. Then the most important part and most impactful part for me personally is kind of being in dialogue. I'm a doctor. As most of you know, I'm an obstetrician gynecologist. And to be face-to-face with you and being in this with you is really important to me. That's how I practiced for 20 years and how I wanted to offer offer this opportunity as well. So with that, I'll get started. So here was the goal. The goal is to give everybody in our organization, but the nurses, some kind of plan that was sustainable for the future from a cost perspective of the plan, and that was a very, very good health plan. So we wanted to do both of those things together. That is our goal. It's very much felt, and I'll show you why, that the current nurse-only plans are not sustainable from a perspective of cost going into the future. I want to also talk to you about a compromise that was made so that people can maintain those plans if they choose to, but that comes with some sharing of that. So let me talk about that. So how did we get here? Well, some people say that, why Allina only? These other people settled months ago for wages only, and why are you the holdout? Well, our nurse-only plans are somewhat different. We're in a different position than the other health systems. Some health systems, Children's is the one, didn't go to nurse-only plans at all. Other health systems actually allowed for a transition to occur earlier to their core plans, so there's far fewer nurses on these expensive, high-premium, high-cost plans. So we are in a unique position where many, many more of our nurses, relative to any other system, are on the nurse-only plans. We're in a unique position relative to other systems in our market in the number of nurses on nurse-only plans and the cost of these plans, which is rising more exponentially than the other plans. So here's the increase in these plans and the costs. So you can see that our Allina First plan, which is used by the vast majority of people on the non-contract side, so all of our 30,000 employees and their families who are on these plans, the Allina First is our most popular plan, and that, you can see the premium rise over those 6 years is very different from the green plans, which are the nurse-only plans. So the premiums for the nurse-only plans, because of their costs and how the costs are rising more quickly. So why are these plans more costly? Well, these plans were designed in the 1990s. There's very few of these plans left in the country. There's under 5% are like these plans left because they didn't necessarily incorporate changes that were occurring in the marketplace. So for example, they don't necessarily, first of all, there's more administrative costs. You can see that, gosh, there's more paperwork and everything to administer 4 plans or 8 plans going forward. So there's some that's that cost. But a lot of it's aligning on, okay, higher premiums and then out of pockets afterwards, but that doesn't also allow for things to be more utilized like appropriate generic prescriptions or convenience care or things like that about how you use care. Now, I know nurses are really smart about how they use care, but again, these plans, how you use them, how you support your healthy lifestyles and things like that, they're just not the same as the current plans, which actually are less costly because we share in some of the costs, but also it incentivizes people to use the right care at the right place at the right time. So that's part of the savings that comes on too. And again, I'll say that while some will overall, there will be some cost and some increased costs associated with that. I'm going to be just open and honest with that. There will be increased costs associated for many. We're trying to offset that in certain ways with lower premiums relative to these plans. Some nurses, we estimate it's probably in the 10 to 30% range, will actually pay less because the premium cost for the Allina First plan is $1,500 less per year right now as it stands. So some will pay less, but many will pay some more. And I'm just going to be, upfront with that. So what do you do about that? But at the same time, these increase, which we're now about, it's about a $30,000 per year health plan. We pay about 80% of that cost right now. Nurses share and pay about 20% on their premium costs. But it's just the rise is going so rapidly that it's not sustainable. If you add to that the proposed Cadillac tax, these are Cadillac plans as designated by the federal government, then that tax is 40% after it was supposed to be 2018, now they kicked it to 2020. So the Cadillac tax is 40% on top of that. Then it gets to be exorbitantly more expensive. Now the Cadillac tax, I'll be honest with you, they kicked it once, maybe it'll go away. It may not happen. But that's what's proposed now, and as some of our community members have said, do you have any business as a not-for-profit health organization even offering what's been defined as Cadillac plans to some of your employees as a not-for-profit. So I'll just say that that's some of the things that we did. So here was our initial proposal, and I want to talk to you about what's the difference between what we proposed to do then and what we propose to do now. There's one thing that hasn't changed. The one thing that hasn't changed is that we feel that the cost and the sustainability of these plans is not possible. So we feel like a transition to the health plan is what is needed. Our initial proposal was that over time, we said 2 to 3 years, that everybody should transition to our core health plans, rated as Gold Plus plans. We'll talk a little bit more about those plans going forward. But our initial proposal was that everybody should switch to those core plans. We changed the proposal, I think, in a substantive way. And I want to explain why. Because we listened. There were some people who said that, and appropriately so, especially people who are at the stages of their career advanced, who have chronic illnesses that they're trying to manage, who say, gosh, I'd much rather pay upfront a high premium and not have out-of-pocket expenses thereafter. We said, okay, let's change it. You know, there's some people who want to make that determination themselves. So how do we do that and actually share and have people make the change when they choose to do so rather than us telling them, okay, by a defined date, we'll do this. So the way that the proposal changed was 2 things that happened. One thing is that the nursing union proposed that 2 of the plans be eliminated. That represented about 5% of the nurses. That was great, you know, because then we started talking about the health plans. This is how we then compromised, and we said, okay, instead of having a fixed date by when these plans should stop, let's open it up, say these plans can continue, but as the costs increase, then we have to have increasing cost share. And that's probably a fair way to do it, but it lets the nurses determine when they want to do it. And I'll tell you several, and I've had hundreds of emails now and talked to dozens of people, employees that aren't involved in the nurses contract and nurses. And there's some that just said, hey, you know, I'll pay the higher costs. I just want that peace of mind that there's nothing much out of pocket after that. And this allows it to do it. We thought it was a reasonable compromise. Okay, so what about the cost sharing part? You know, I said that, you know, increasingly those costs would be then shared by the nurses, so what does that mean? So what it means is that after 2017, not until 2018, we would pay the 2% of the increase in premium costs, and we would have the nurses who wanted to stay in that plan pay whatever increase. We think these plans will continue to go up like this, but if it's a 2% increase, we'll cover it. We're still going to cover then 80% or so of the cost of the plan. If it's a 4% increase, then we'll actually, you know, 2% will be ours, 2% will be the nurses. If it's a 6% increase, I'm just going to be totally open with you. It would be 2% us and 4% the nurses. That's what the current proposal is on the table now. But at least the nurses, many of them who wanted to make the decision of when to switch themselves, get to decide when to switch, when that cost is worth it and when the cost is not worth it. So that's the change that we made. We think it was a compromise for both sides, that they'd have the option to stay in, and then, as I said, these would be increasing the share. We would continue, as I said, to pay for the majority of prices, and then you heard me say, too, we pay for 2% of the increase, and then the Cadillac tax, if it occurs, is proposed, as I said, for 2020. That gets to be an unsustainable cost, we feel, like for everybody involved, for nurses and the organization, that would fall there then if it happens. So here's the health plan proposal. Modify those choice and advantage plans. We accepted the union's proposal on that to add some minimal deductibles and increases. And nurses who enroll in the core plans can't re-enroll then in the nurse-only plans after they've made the decision to switch. What's not changing, we won't make any changes to the advantage or choice plan, and Allina Health will still provide the premium subsidies, and eligibility still is maintained if you work 2 days a week, which is a good benefit to have, and it's quite honestly a richer benefit than most people getting full health insurance at 2 days per week. Again, you know, it's really hard to know. Gosh, how do you know what to trust in this? You know, are these plans good? I've heard they're going to cause financial ruin. I've seen the case of Margaret, who paid $162,000 out of pocket, and that she was going to, you know, have to sacrifice all that if she didn't have her plan. We wouldn't subject our employees to any kind of risk of financial That is not a way to retain and attract great employees. Why would we do that? We couldn't. So all of our, our lab techs, our environmental service workers, our, nutrition service workers, our physicians, our leaders are all on these core plans. And I can tell you that we've done case scenarios. Many of you have seen it, and I'm so sorry that I know you've gotten so much information. But we've done case scenarios about like people who have had a cancer diagnosis and had complications and had difficulties and had all the challenges from their health. We don't want them to focus on financial challenges in addition to health challenges. And they can tell you on the core plans that they've been well cared for. And so I want to say that we wouldn't expose you to not good health plans. And if you don't know who to trust, there was an independent study done by the Kaiser Family Foundation that said, yes, the current M&A plans are platinum plans. They're Cadillac plans, they're platinum plans. They're richer plans. But the core plans that we're offering are above average plans and very, very good plans. And set at a gold plus premium level, and that was again an independent survey. We didn't have anything to do with it. Public radio did, but we didn't. And just saying that what we hear from our employees is they work well. What we hear from an independent source is that they're gold plus plans. It's not taking health care away. It's changing it to a different health plan. And then the scenarios you all know about, but they're certainly available if you choose to look at those. And they go from everybody who's well to some people who've had catastrophic illnesses. And I know each one of these things turn on your own individual circumstances too. And we have people available if you want to look at those things from Blue Cross Blue Shield who will tell you, gosh, what is the impact for your own individual care and circumstances? We heard from somebody today that there's no way that they'll pay for this cancer drug out of pocket. It's $100,000 per year. The formulary on our core plans is the same formulary on the nurse-only plans. Those same drugs will be covered. So just make sure if you have individual questions, we'll find a way to answer, gosh, what's the impact on you as an individual? That's part of our job. All right, let's talk just about two other really important issues for all of us as well. So I want to talk about workplace safety, and I want to talk about staffing. So the workplace safety piece, I think that we've always benefited. Some of the most challenging times is when we're right in the negotiation cycle, but we've always had ongoing conversations with the union and the representatives of the unions about how to make our organization better. And those conversations have benefited us. This is one that's going to make us better, too. Having nurses have a greater voice in how we deal with workplace safety issues that unfortunately are escalating in our organization, are escalating across the country. We have to decide what's the best way to do that. So we agreed to all of the things that I think appropriately the union put in place. There they said, let's make sure we have nurse representatives on our workplace violence prevention. Let's give labor management committees the opportunity to review data about incidents that occur and try to figure out the best way to deal with those in the future. Let's provide all nurses at least, and I'll emphasize, at least 2 hours of training per year. And so those were all things about giving nurses a bigger voice that will improve, the environment of our care, and that's important not only for nurses but for all of us. The one thing that's not in the contract, because we thought it was more of a broad issue, not just contractual one, but one we'll deal with and have dealt with, as I understand with here, is this one. I talked to a lot of nurses in the emergency rooms, and I remember one saliently at Mercy telling me about how she's so devoted to the care of her patients, and it's just downright scary for some of the work safety stuff here. So what do we do? One of the things we do, we have on all the metro hospitals, the ones that have emergency rooms, Unity, Mercy, Abbott, Northwestern, and United, all have designated 24 hours per day security. But not all of them are right at the elbow in the emergency room especially. And there's no reason, it's different when you feel safe with somebody at your elbow or whether you feel safe with somebody who's distant. So I understand Ben at Abbott, if I'm not mistaken, that security personnel is not present in the emergency room.
Stationed in the emergency department.
Now stationed in the emergency room, we have to do that everywhere. That's one thing, again, that we can enhance our safe care, especially the people. I hear about it from other units too, but that emergency room is really a hotbed for people, and we need to do that for all employees. Staffing's a tough one. I mean, we want to make sure that there's an appropriate staffing and resources to take care of the needs of our patients. We had two different ways of approaching this, frankly. On the union side of things, as have been for a long time, it's been on strict staffing ratios going forward. We were trying to propose a situation where we use kind of evolving, have the nurses help us choose an evolving acuity-based system that took into the nurses' consideration over what the needs were of the patients and also the acuity of care that the patients brought in. So for example, you all know, and I've had patients like this too, where there's a patient that you have who probably just needs some compassionate care and a Tylenol every 4 to 6 hours. That's rare. That's rare in the complexity compression that it cares today, but there's some like it. And then there's others who have 6 medications, have 12 chronic illnesses, have a social situation that is difficult, have family members that are at odds with each other. And those are the things that we're trying to all put into, like, how does this work together? A fixed ratio, we thought, gives less of our opinion, not shared. We feel like a fixed staffing ratio gives less of those considerations to the nurses, where this puts the nurse's judgment along with the acuity of the patients, and it might be that sometimes the right ratio is 1 to 2, and it might be sometimes the right ratio is 1 to 6. So it puts more into that. So we just had a difference of opinion from what I understand, that this was not addressed in the other wages-only agreements across the metro area. We didn't get to the point where we addressed it either, and both sides dropped the fixed staffing ratios. As far as I understand, we dropped the acuity base because some people were saying, oh, it's staffing by computer, which it was staffing meant to be, staffing by, and robot, I heard that too. Staffing by that and the nurse's judgment as to what the social situation and what the needs of the patient were, both were trying to take care of. We just approached it differently and couldn't agree. Wages. So this, we matched the 2% across the board that all the metro hospitals agree to going forward. That's in addition to the current steps scale increases that is in the contract that we left untouched. So for the first 10 years, you are a nurse, you get step increases that average about 3.6%, so this 2% is on top of that. For the next up to 25 years, you get about 2 to 3% increase, this 2% again is on top of that. So, and then I'll say the other thing we did is we tried to look at, okay, a lot of people say we're changing the health benefit, and that's hard. But how do we, is the whole package, how's the whole package setting up for people relative to others? So every job we have here in our system, we actually look at market data to say, are we paying fairly? How are we paying relative to the market? Every role we have, we look at that data. This is no different. And so we got data that says, how are our nurses compensated fully, the whole package, relative to other nurses in the country? And I'll just say what we learned statistically. We learned from Sullivan Cotter, our third-party person who looks at this, that relative to the other nurses in the country, we are paid 33% more on average. Well, that doesn't fit, right? Because, again, the country doesn't look like us. There's rural areas, there's lower complexity areas, so that's not really a fair comparison. So then we say, well, let's look at premium care markets. Let's look at New York. Let's look at Atlanta. Let's look at Phoenix. Let's look at some of those markets and say, okay, for like markets, what's a comparison? And the data from that comparison study said that we're about 5% above. And the reason I'm bringing this up is because we don't usually talk about everybody's salary things with everybody, but the reason I'm bringing it up is because it's like many people have brought up the issue is, are you being collectively unfair with what you're paying nurses? So we had to look at that, and are we being, and we feel like we should. I think we have one of them, and I've told you, and I've worked with you. I think we have some of the most incredible nurses in the face of the planet here, and I think we should pay well for those nurses. But I don't think we're paying unfairly low, and we had to make certain of that. All right, so that's it before I want to open it up for questions. Before I do so, just let me say that a couple things. One is that there's nothing, I don't think there's anything harder as a physician and a caregiver is to have people think you don't care about them. And that's just not the case. And I said this to other settings too. I wish there was a way to open our hearts, open our minds, have you in every meeting of our leadership team and see how much the focus is on safe and quality patient care, on support supporting our employees in the best possible way for the long haul, and making sure that we support each other in the best possible way. I think you would see that. I know that we don't all feel it now, and I know there's a spectrum of emotions in this room from I'm really mad and this is unfair to I don't really get it. What's this really all about? I talked to one of our beloved chaplains here, Kate Herman, who just retired recently, and she said, you just wish everybody would bring what are you carrying, what are you afraid of, and how do you care for each other in the best possible way. That's what I wish to, and I wish that we could get a resolution that allows us to focus on what drives us all here every day, which is how do we impact lives in the most positive way. So with that, let me open it up for questions. I want it to be respectful. It really has been at all the dialogues I've had been, and I want it to be direct at the same time. So please go. Yeah, question.
Diane Johnson, 39 years here at Abbott Northwestern, and I've loved every single year of it. Thank you. I know many people. What I have to say, and you made a very good presentation, but Penny and Ben and everybody from Allina, I don't think you realize, oh, by the way, I'm also on the M&A board of directors, and I've been there for many years. So I can also tell you that this is outward, and my concerns, and many of our 2,000 nurses here, maybe 5,000 across the city, are concerned about the union busting, because this is downright, absolutely union busting. It's been going on for a long time, little by little, and this is what's happening. This is our concern. We are a union. We are not right to work. I know you talk about 33%. But I also am nationally very involved. That's fine. That's the right to work states. But I know what New York gets. I know what Massachusetts gets, Washington, D.C., California. I know what these people make. And we are not overpaid, folks. For what we do up there and what we have to know and the knowledge and the expectation, we are not overpaid. Abbott Northwestern nationally has a sound reputation. A sound, very good reputation. You are losing many of the good nurses that created this. And that's why I work at Abbott. I came in 1977 because it was independent thinking. I worked with the physician. I was able to make critical choices for the betterment of patient care. So it's as outright union busting. We nurses are not. We are going to stand up for our union, folks. We are vulnerable out there. We need this union to help protect our rights.
So let me say what I've said at every forum. I believe in the right to organize. I believe in the right to advocate. I believe in the right to protest. This is about transitioning to an unsustainable health care plan to one that's sustainable. It is not about union busting. I'll just say that then. I don't know if you want to add anything to that as well.
Yeah, I think the hardest thing is when you're in a negotiation that's challenging, how do you act in a way that's respectful? And I think that that's what we've tried to do. If it's felt differently, that's our bad. What I think we want to do is try to get to a place where we continue to work with the union to solve problems. And we've had that culture here. We've done a number of things outside of the contracts to solve problems, to work with the union. And I want to go back to that and be in that position. I have no desire to see the union go away. I think it's the right thing. I think it does great work. I just think we have to find a way to get to an answer on this contract so that we can move forward.
But yet Diane Johnson's been here for how many years? 39?
39.
And for the last 14 years, she hasn't had a step raise.
No.
So she's at the 25-year mark,
Yes.
and then it's it. So she doesn't get all the perks that everybody else
No,
gets.
no.
Her income is stagnant.
So
Because
is
there's
mine.
no
I've been
step
here
raise.
43 years.
Well, exactly. And I'm not there yet. I'm really close. I don't know if I can handle it though. Here.
But this is what happens in union busting. And this is very obvious. Better read up on it. They zero in on one important thing. Healthcare and what you preview at Allina is not the most absolute thing the nurses are after. We want acuity, not ratios. We want acuity for our patients. I work in patient placement. I know what happens when these nurses cry and say, please, can I have another nurse? And the manager is saying, no, they don't need one. And guess what? They close the unit. We have nowhere to move with these patients coming into us. 80% of the time this summer, this hospital and spring have closed, it's due to staffing. Now, you'd go check up on that. It's because of staffing. We've got the beds, but we do not have the staff. Now, tell me this is not union busting when you go over our wages, the health care, the ratios.
Well, with non-nurses, it's none of our
And you know what?
business.
When you talk about non-nurses, and we should have the same health care, SEIU gave up their health care. We all had the same health care way back in the 70s and the 80s and the 90s. It was SEIU that said, no, we don't want to fight for health care because their contract was immature next to Abbott Northwestern's nurses. They fought for something that was very important to them, and health care wasn't at that time. Health care has been important to us since the 70s. I have been around since 63, and it's been important to us. We know what happens out there. I don't want my husband or my children or myself to be vulnerable to some of the things I've seen in healthcare and what's happening today. I also am strategically working throughout the country on a healthcare plan for all of us, Medicare or whatever you want to call it, for all of us, head to toe. It's going to be coming, folks. But I'm I'm much more concerned about the union busting of our union. It is strong, it's the strongest in this country, and I want to maintain that.
Thanks, Diane.
Okay,
Thank you for your,
I'd
thank you
like
for
to
your
speak.
good.
I'm a 31 years here, and I have worked with you, and I adore you. I adore you. I do. But, and I've written letters to both of you, and I feel very strongly that after 31 years, that the respect that I get is not driven from Allina. What I have in my contract and what protects me and what has provided me with the most economic security, the most security from violence in the workplace, is not something that Allina has given me. It is something I've had to fight for with each contract. Good job. Absolutely fight for, not because Allina thinks I deserve it, because they finally think, well, we'll have to give in. You've cut our coordinators in the heart hospital. I have lost pay because of a mistake made by your human resources department that shorted me $6,000. M&A had to go to bat to get 50% of that back to me. Not because Allina thought I deserved it, but because I had to fight to get some of my lost pay. Now, if you would have overcharged me, or if I had received that, you would have wanted all my money back. And one last question for you is, what is the last time your entire check, your entire income for that month went out the door for the price of your premium and the price of your deductible? I work alongside of people, fortunately not nurses, but techs and housekeeping, who one incident into this hospital took their entire month's income. And I think, you know, M&A, we have good benefits, and you get what you pay for, you know. We're expensive for you. We are. But your other employees deserve that too. So when I have no money for their house payment and their car payment and other things because all of their money went out to their Allina program. And I'm very sad about that.
Yeah, and also I'll just say, first of all, Chris, we care for a while we get together, and I adore you too. And I appreciate.
I know it's hard. I
and
really
respect-
know
It
it's
is really
hard
hard,
stuff.
and it's one of the reasons that we try to put in place for people who want to continue the plans, to continue them. But we have to be able to find some way, because it involves our ability to reinvest in our facilities, our medical equipment, our other jobs, our raises going forward, to make sure we do something to help in.
And I
control
see
this.
where you put money for cardiac surgeons. I see it. And I think you're better invested with your nurses.
Other questions here? Yeah.
Me?
Yeah.
Morning. Mary Ann, Station 30, cancer, 32 years. With all due respect, Dr. Bockiewicz and Dr. Wheeler, I find it to be an interesting strategy that you would invite all hospital employees to discuss the nursing contract proposals and issues. Very interesting strategy. Therefore, I want to ask you, Dr. Bockiewicz, and you, Dr. Wheeler, will all of us be invited to your negotiations for your next salary? Because we would be there. We would be there. Is that how you respect us, by inviting everybody in the entire hospital to discuss our issues? I think you do not respect us. You have no idea what we do or who we are. None.
Well, you're not going to be able to convince you. There's almost nobody that, and again, not in this setting, going to be able to convince you, but one of my proudest days was when I was made an honorary nurse one time. The respect and what you've done for my own patients and what you've done for our organization is there, and I know that not all of you are going to believe that. As to inviting all the other employees in, this is an issue that's gotten to the point where we have to look at, safe care and quality of our patients, and it's been very difficult. Everybody is affected by this. If I ask for, and I won't, but if I ask for a show of hands as to who in the organization is impacted by this and the challenges that we have together, there's not one hand that can be raised. We talked about it. We tried to do it in the best possible way. This was the way we determined was best possible. Other questions? Yeah, way back in the.
I'm a very reasonable person. I also feel very sad that we're losing nurses. I'm trying to convince them not to leave, and it's just very frustrating. But I'm about the facts, and I feel like there's a lot of misinformation being spread around. So just a clarifying point, your 5% that we're getting paid higher than other areas that are similar to this hospital, how would that change if we switch over to the core plan? I'm wondering, because my concern is our total compensation package includes our health care. And I feel like we're 5% higher because of our higher plan and our Cadillac plan that you claim we have. I'm concerned that that 5% that you say we have is going to be less than that. And I'm concerned that, 2% isn't going to make up for all the costs I have. And, I'm concerned that what I'm hearing from my support staff is we make 33% higher than everyone else, when I appreciate you telling me the truth today and telling me it's really 5% for a similar area. I really do appreciate that. But the misinformation being spread out there is 33%, and that's just hard to face every day.
I mean, I can't, quite frankly, I don't have the numbers. I don't know if anybody does as to what that will mean. And I'm just going to be always honest and open with you. I don't know what that will mean, whether that 5% becomes 2% then or something like that. What I will tell you and what I will commit to and what we as an organization will commit to, we will always look at those comparisons and always try to keep people, and work with the unions, quite frankly, to do it. Always keep people at something that recognizes the extreme talent we have here, because the retention and retaining of you and attracting people is so important to us. I was born in this hospital. I have tremendous, and I worked here for over 20 years as a practicing physician as well. There's nothing that within our appropriate powers that I want to do to dissuade that. Times do change, that's true. There's some excitement that comes with those changes, and there's some trepidation that comes with those changes as well. But I will guarantee you we'll always look to make sure we're paying and being very fair about what we pay for every job classification, including nurses.
Yeah.
I have a comment. My concern is that yes, what affects nurses affects everyone, but also every other job description affects everyone. They're all intermingled together. So my concern is that we're all very aware, not just nurses, everyone is very aware that Allina is getting richer and richer on the top. That's, made everybody knows this. Banner year last year, right? And yet we're losing. You're inciting things with the nurses through this negotiation. We don't have enough staff to do the job on the unit safely. I work with a 20-some-year-old girl who got a concussion and a black eye. We don't have bedspreads. We don't have enough housekeepers to come and clean.
really disheartening. And I don't know, I'd like to understand a little bit more about how Rich is at the top, because we are trying, actually, even some of these things of transitioning to the core plans is so we can reinvest in our people and care. And some people say that, okay, you're profitable, so why can't you do this? Well, we're not for profit. We make 3% profit, which is relatively narrow compared to other organizations. Our profit margin has actually declined with reimbursement drops over the time. Our expenses, because of pharmacy costs going up 14% and other things, our expenses are going up about 4%, 3.5% to 4%. Our revenues are going up about 1.5% or 2%. That's the changes that's going on in healthcare now. So we have to try to say, okay, how do we do that in the best possible way? With the revenue sources declining and with the expenses rising greater than the revenues, how do we balance that in the best way? And the focus, and again, I think you would all really be proud, whether you believe, some of you believe it or not, in every leadership team meeting, and how the focus is on the patient care and how we use these, how we be good stewards of our resources to make sure we do that in the best possible way.
Do nurses sit on that? Do nurses sit on any of your leadership meetings?
We always have forums for nurses to opine on that, and I'm trying to think about, there are nurses in our leadership team. There's some that run hospitals.
No.
On our leadership team. We try to bring other voices, your voices in. I don't know that you'd always that be the most productive time. I think your time you'd like to have spent next to the patient care rather than wrestling with some of the issues. But we always invite and always have crowdsourcing of what decisions we're going to make and how we balance that off in the best possible way. That's how I want to lead. Is like by inviting issues in. I won't satisfy every voice. We can't come to a consensus on everything. But I will always listen and take every counsel into things going forward. Yeah, back there, please.
Yeah, hi. My name is Corey Waz. I am a nurse in the emergency department. Been here 9 years. I don't know if you remember me, Penny, but you and I sat across from each other about 1.5 years ago and talked about our issues that we face every day in the emergency department, from mental health and our violence that is so predominant. So I just want to talk about that for a minute. I am very involved in our violence prevention training at Code Green. I'm on the steering committee. I'm a workshop. I instruct. I teach. We do a lot of work in the emergency department. And my concern is that you guys have never seen firsthand our violence. We go through this every single day, every shift. Verbal, physical, mental, emotional. It is predominant. It is there. It is in our face every single day. And we have come to accept this culture that that's okay somehow, and it's not. We talked about you coming down and shadowing me. That never happened. So my question to you guys is, where have you seen that firsthand, like we experience it every single day in the work that we do here? Where have you seen that? Where has it been? And what has your response been to that? And when you talk about the violence, what we're asking for is not just training the 2 hours, because that's the law. That has shifted. We have to train everybody. We don't want just that. We want more stuff, more security, more things at our disposal so that we can protect ourselves when we walk into the room, when we walk into this job every day, so we aren't exposed, because that's what's going on. And we don't have 24-hour security in our emergency department. I don't know where that information came from. Is there a desk there? Yeah. Is there someone there all the time? No. It's not 24 hours. We've been asking for that for a very long time, and it's not there. So what can you do and what can you say here to address that issue, that we face this every single day we walk into this establishment?
Well, I think that I've done a number of tours in the emergency room. I've seen some of the issues. We have increased the amount of security. We've staffed security to try to have 24/7. If they're not getting there, I will work on that and commit to that being there. That's an absolute that needs to happen, and I will commit to that. I think that from my perspective, trying to sort through that and understand what other things we can do besides the security, because that trying to balance being respectful of mental health patients and treating them in as kind a way as we can, and yet not tolerating violence is a key balancing that we're all facing, and I think we need to be better at it. And I hope that the things that we're doing in this contract help move that forward, but we need to do things beyond that if we want to get to a place where we're going to be feel better about that.
And it's certainly not just mental health issues.
It's not just mental health
It's
issues.
also mental health.
So if that's an absolute concern, why is there refusal to make that a contract point that there's a 24/7 ED staff member? If that's absolute, why is that a point of contention?
No, I think that from my perspective, the question of what is contractual and what's not is always something you have to balance. How do we decide? What do we put into contract language? What do we do and work on? And what I would say is there's a number of things that we do to support staff that are not contractual around whether it be safe lifting when we address some of those issues, whether it be additional support around rapid response and other pieces that we put in to try to help support